Without further ado, Joe Francis and Sailesh Konda are the pioneers of really digging into private equity conflicts of interest and the impact it's had in dermatology. So we're really not alone in fighting this. As mentioned by Dr. McNamara, we might have pioneered it and the cancer has spread, but the dermatologist can help us stop the melanoma early, I guess. Thanks, guys.
Thanks, Mitch, for having us, and thanks for everything you're doing from the advocacy front. So Dr. Francis and I will talk about the top 10 lessons in advocacy from dermatology. And disclosures, none relevant to this talk. And just for clarity, Dr. Francis and I are not speaking or commenting on behalf of any organization. And I did include a little photograph for the two of us down at the bottom. This was actually in December of 2017. It was the first time Dr. Francis and I spoke on this topic to our faculty and residents at the University of Florida. And since then, the awareness of private equity in our field has exponentially increased. And we've learned countless amounts of things about private equity and how it's infiltrated our field. So I'd like to share some of our pearls with you over the next half an hour. So with dermatology specifically, our landscape is obviously, we experience private equity later than ER. So we're still in the early to mid phases of it. But historically, we have 35 unique private equity backed dermatology groups. And the first one entered the market in 2009. Here you can see a chart of US private equity activity in dermatology by year. I don't have 2018, 19 onwards on here, but you can see from 2010 to 2017, it gradually increased with an exponential increase from 15 to 17. We do have more recent numbers, and it is starting to show signs of plateauing from 2018 to 20. And here you can see, here's a list of all the known private equity backed groups in dermatology since 2009. Not to belabor it, but just big overarching points. The ones that are in red are ones that have gone defunct or insolvent for various issues. The ones that have stars next to them are actually groups that have recruited influential leaders from our national societies, whether they're presidents of our societies or board members, anybody in the hierarchies of leadership. And the ones that are in that light blue color, they are the known groups that have formed an alliance or trade group, which I'll talk about later. And here's a map of the United States. And this map we set up to show the number of unique private equity backed groups vying for offices or consolidation in each state. So as you can see, Florida and Texas have 9+ unique groups. They are hotbeds of consolidation, as are the West Coast, Mid-Atlantic, Northeast, Southwest are the hotbeds of consolidation in the US. So one of the first things we've learned in our advocacy in private equity in regards to dermatology is you have to learn the private equity playbook. You have to understand how these guys and girls think. So one thing I like to do is I like to review their own literature, go to their conferences, look at their slide decks. And one interesting slide that we found from Healthcare Services Private Equity Symposium is audience response system to the audience, asking healthcare executives and PE executives, what are the top characteristics of a successful CEO in a healthcare services company? Many of us here would think it's 1, knowledge of the healthcare industry, or maybe 3, financial acumen. That's why they're here with their deep pockets. But ironically and interestingly, the number 1 characteristic they think they have is number 5 is vision, closely followed by 2, which is 31%, ability to deal with change. So this is why they think they're here at the table for medicine. And so in order to learn the private equity book, I recommend reading the PE literature, including their legal and accounting literature to understand their vision and how the cogs and mechanics of private equity consolidation work. Some quick examples, PitchBook. I'm sure many of you know PitchBook. One of the weaknesses of PitchBook, though, is the deal information in PitchBook is self-volunteered by PE firms, so maybe incomplete at times. Also, Ernst & Young and Deloitte, these are big top 4 accounting firms that work with private equity. Also attend and participate in their meetings and symposiums. McDermott, Will, and Emery, they have weekly or bi-weekly Zoom meetings, actually, where you can easily participate and see what they're talking about, along with joining symposiums such as HCPEA, which is the Healthcare Private Equity Association. I also left 2 images of 2 books that are helpful to read. I do recommend Jeff Hook from Johns Hopkins recently put out a book, The Myth of Private Equity. I just received and started reading it, but so far it's an excellent read on learning the mechanics of private equity. Another slide from the same conference, which physician services subsectors drawing the most transaction attention in 2018? dermatology was the kid on the block, the hot topic with 55% in 2018. But everything goes in cycles, as you'll see. And so why did private equity like dermatology at that point? Aging demographics, more skin cancers being diagnosed, increased healthcare access with ACA. Dermatology has pretty strong financials, pretty well reimbursed, relatively fragmented. As of present, estimates are about 15 to 16% of dermatology is private equity backed. And then future projections, 2015 had about 12 billion in revenue. The projections before were about 16 billion in 2020. That's probably overestimate given the COVID put a dip in all of our practice revenues. And so what is their model here? How do they do this private equity backed groups? As you guys know, they circumvent the corporate practice medicine laws. You form the PE group, usually with a professional medical corporation and a management services organization. You have to entice a late career and retiring dermatologist to sell to your private equity group. You got to recruit the residents early career dermatologists to work for your group, expand your private equity group, maximize your EBITDA, and sell to the next highest bidder. That's essentially the model. Rinse, repeat, do it again in another specialty. And here's another slide that shows really the mindset of these groups. This is a slide lifted from AHLA, American Healthcare Lawyers Association. And forget about the rest, but on the right-hand column, you'll see success of the strategies dependent on the loyalty of physicians. And two key things I'd like to highlight here is, one, they ask, will shareholder physicians continue to work at historical production levels for the promise, in quotation marks, of equity returns? And two, will non-shareholder physicians continue as employees or contemplate private practice again? And these are two of those cogs, the mechanics that need to continue to happen for the model to continue to survive and do well. And they know this too. In Healthcare Law Monthly, in April 2019, from their own words, from their own mouths, they say in the private equity cycle, one critical strategy that private equity investors deliberate is the timing of the window of opportunity, so as to successfully exit an investment at the best possible purchase price without being the last one standing. Essentially a game of musical chairs, and you don't want to be the last one standing when the music stops. And to my point earlier about everything going in cycles, same conference, 1 year later, they asked the same question in the audience: which healthcare subsector excites you the most today? You would think, oh, maybe dermatology is still at the top, but actually, a year later, they said, no, it's behavioral health. So you can see how it's this very cyclical phenomenon, and they consolidate different specialties at different times, depending on the landscape. Number two, understand the evolution of private equity. Dr. Francis and I wrote a succinct paper about the evolution of PE. It's in Clinics and Dermatology. I recommend you to read it if you get a chance. I'm sure there's some similarities to ER, but also some differences. But essentially, to summarize it, there's 3 stages, at least we've seen in dermatology. Stage 1 is the physician consolidator. That involves the PE early consolidation, the PE buyout, building a brand with a platform practice, growth and expansion with add-ons, maximizing EBITDA, and preparing for that first flip and the eventual buyout. This is the point of the evolution where that physician face is still there in the front of the company, really having a face and a personality and I guess a comfort there for physicians to join. And as you go into stage 2 and stage 3, the successive flips, that physician gets pushed into the background gradually, and the PE takes more and more driver's seat in the company. And a good case example, I'm sure you have those case examples in ER, but an excellent case example in dermatology is advanced dermatology and cosmetic surgery. This has been the kid on the block the longest in dermatology, started in the late 90s, 1998, with about 5 to 10 offices, gradually built up over the 90s and early 2000s. The first private equity investor came in to invest into Advanced in February 2012, which is Audax. You can see as soon as they came, there was a big jump in the number of offices that were acquired. This is tracking the number of offices on the y-axis. And then again, when Harvest Partners came on in 2016, another big exponential jump. And then actually you can see there's been a decrease in the number of offices now. So one broad statement is that these companies prepare to flip to the next buyer, they may close underperforming offices in dermatology. They have low individual EBITDAs to make the balance sheets look good for the next buyer. And patients in the process can lose access to dermatologists in those areas, ultimately affecting patient care. So who's the next owner after the flip? As we know, could be another PE firm, larger healthcare conglomerate, an IPO on the stock market exchange, or sell to an insurance company. The last, they're all of concern, but of special concern is, they say keep calm, we're under new management. But recently, as you know, Denver's DaVita, they decided to sell their physician network to Optum, the physician acquisition arm of United Health, for $4.9 billion. And actually, with this acquisition from the Pacific Northwest, there'll be many dermatologists that are now directly employed by Optum, essentially an insurance company. Number three, you want to connect with physicians from other specialties affected by private equity involvement. In the beginning, Dr. Francis and I, we were in silos. We were the first year or two, we were just dermatologists, all we knew. We were the only ones talking to others in our field. But we learned that's not the way to go. And as Dr. Mitch Lee has shown us, it's best to bring us all to the table together so we can discuss and share our experiences and what we dealt with in our individual fields. And so where's PE in medicine? It's everywhere. ER, primary care, optho, derm, radiology, GI. I'm not going to belabor all this. Nursing homes, orthopedics. It's in every facet of medicine. So, and there's also, not just in derm, there's other specialties writing about this too. Ophthalmology, OB-GYN, ENT, radiology. And Dr. Francis and I realized that it's important to connect with these other researchers, both one, to foster exchange of ideas, and two, get ideas for new research down the road. And we've done that, and we hope that ER will find this a useful avenue as well. And number four, be aware of private equity-backed trade groups. In derm, I'm sure you, similar to doctor-patient unity, we have some similarities in dermatology. One thing we always hear, you may hear this in ERs, every private equity group says we are different from the other private equity-backed groups. It's like a broken tape recorder. And to that, I say you are who you are by the company you keep. And one thing, I still remember the day that we discovered this. I won't give you the whole background of the story, but essentially, we had heard there was an informal group of private equity groups in dermatology that had been meeting to discuss their shared issues or experiences, so to speak. And we didn't know what they were talking about, but after several months of diving deep on the internet, looking through corporate records in individual states, we found this group in Delaware called the Dermatology Practice Support Alliance. And it was incorporated in May 2016. No public-facing website, no discourse whatsoever. And it was incorporated by, and the paperwork was filed by Christopher Kane in California. And he's the current CEO of West Dermatology, which is a very, top 5 largest private equity-backed group, and is on the West Coast and Southwest in the United States. And so who is Christopher Kane? Christopher Kane, as I said, he's the current CEO of West Dermatology. He was previously the CEO of Pacific Pulmonary Services, provider of home oxygen therapy. And while he was there, he climbed up the ranks in the company, and he created an industry coalition led by CEOs called the Council for Quality Respiratory Care. And this relatively innocuous name lobbied for their interests on the Hill. And the FBI ultimately raided PPS in 2012. They agreed to pay $11.4 million to resolve allegations of violating the False Claims Act and for a cross-referral kickback scheme. And ultimately, they laid off a good portion of their employees. Now, as one of the other presenters alluded to earlier this morning, I believe it was Dr. Marion Mass, she talked about open payments and Open Secrets, actually, the website. And you can actually track these lobbying groups to see how much funding they're giving on the Hill. And you can see they started out giving about $60,000, $70,000 a year, but in the last 4 or 5 years, their lobbying money has gone up to $270,000 plus, easily $250,000 a year, lobbying for their own interests on the Hill. And so we've tried to track this analogous group in dermatology, but as of present day, we have not been able to track any funding that they're giving directly on the Hill. But it's important to know this group, we call it the Big 10 in dermatology. These are the Big 10 largest groups that we know, at least on paper, comprise this lobbying group or trade group. And when you look at the market share of this group, not of dermatology, but just let's take the private equity sector in derm. And if you look at this Big 10 and see how much does the Big 10 control compared to the 35 private equity groups, they control essentially 70% of offices, physicians, and extenders in the private equity landscape. So one could assume or possibly that they don't need to invite the smaller PE groups to the table because they control the market share, at least in the private equity sector. And to this day, we don't know what the lobbying priorities are of DPSA, but we're following them closely and we'll see what transpires. And lastly, number 5 is start a job board for transparency. And at least in dermatology, we found the most successful thing is several years ago, we started a group called TBCD Career Center, the Board Certified Dermatologist Career Center. And essentially, anyone in the country can post both job openings and people that are searching for jobs can post what they're looking for and connect. And we have 2,300 members, including current residents, and majority of private equity and recruiter free postings. Private equity is allowed to post, but we are very transparent and we will label it as private equity. So there's a degree of transparency. And we found it very successful and been a lot of success stories. And with that, I'm going to pause and I'm going to let Dr. Francis take over to discuss this 6 through 10 right here.
Hello, everyone. Nice to be here. My name is Joseph Francis. I'm adjunct clinical faculty at the University of Florida, Department of Dermatology. I have no relevant conflicts of interest. I get a lot of ideas from your questions, so please ask questions. So I'm going to start with number 6, and that is we really need to, one thing that we've learned is that we need to publish and respond to the peer-reviewed research and literature. And I'm going to go over the reasons why that's the case. So the democratization of data analysis tools and that policymakers, they really want to look at peer-reviewed sources when they make policy recommendations. So I'm a former computer programmer. I don't know, I'm sure that you have somebody with that sort of skill set in your organization. But data.cms.gov, back in 2014 released, individually identifiable physician payment data. And, it's pretty much a gold mine to looking at practice patterns, especially in dermatology, which is sort of overrepresented in the data that was released, which is Part B physician payment data. Our Studio is a free program. It's very powerful. It's very similar to SAS. I would say it's probably a little bit more functional, but I mean, maybe it requires a little bit more of a learning curve, but I don't think that you need to be a computer programmer to learn it. But I've been able to, download this, download data and do some research on it with our Studio and, sort of develop things like this, which is, identifying, patients with Alzheimer's disease that were being, preferentially injected with steroids at nursing homes, then 75% of them were demented. And this was being done by a private equity-backed group of traveling physician assistants and nurse practitioners. So this is an example of data analysis done by non-subject matter experts that appeared in a journal called Health Affairs. This is a group out of, I believe it's Columbia, Dr. Castellino's group, that wrote this paper, Private Equity and Dermatology, Effect on Price, Utilization, Spending. Sailesh and I read this and we found lots of issues with it, and we were able to write a letter to the editor clarifying some of these issues. We've also had to do this in the past with the same sort of group, Dr. Castellino's group. We wrote this response that was published in the Annals of Internal Medicine. So if you see something in the journals that's that talks about quality of care by PE and it's written by non-emergency medicine folks, then something that maybe you should respond to or do your own research. No one's going to do their research better than you, and no one understands the billing and coding and the nuances of it better than you guys. So this is sort of a press release by MedPAC. So if you're not familiar with MedPAC, the Medicare Payment Advisory Commission, they prepare, it's who Congress goes to when they have questions about Medicare. So they asked them to do an analysis of private equity and Medicare. And the analysis came out in June. So this is one press release that was sort of about a private equity surge in healthcare highlights shortcomings of CMS ownership reporting. And that's basically what their conclusion was, that the ownership of the private equity firms was sort of being masked. and that there need to be more transparency. But if you read, some other press releases about it, like from the American Investment Council, they said, in case you missed it, new MedPAC report highlights value of private equity investments in healthcare. And this is like the #1 search result. So there's lots of different ways to spin it. But in actuality, you can go read the report for yourself. It's pretty interesting. So the next thing I want to talk about is gathering stories and how important it is. This is sort of Eileen Applebaum's advice for us, and I think it was very good advice. Everybody wants to talk about what's happening to them and their abuses, and some of them obviously are bound under NDAs. So I think probably one of the most important things I'm going to say during my 15 minutes is that we need to create some kind of platform for everyone to just share their stories so they don't get lost. There's so many. I actually had one the other day. Somebody emailed me and wants to just talk, wants to tell me their story about what the things that happened to them. And we really need to capture that. So why? Because these stories are very valuable when you're trying to sway public opinion and regulators. And we can't lose them, because if we're going to be disorganized, all this stuff is going to get dropped. So, and the other thing is that PE counters with fake pro-physician and pro-patient advocacy, and we can't have this as the only organized voice. We have to have another organized voice. So this is, again, an example of doctor-patient unity, and there's been a lot of press about it. And then our sort of group is Mitch Lee and Sailesh Konda's voicemail, email, and Facebook Messenger. That's sort of I feel like the interest group now that gathers real stories from PE and employees. So the next is understanding priorities of different docs by their career stage, age, and life situation. We can criticize the system, but don't insult your colleagues that work for PE. So this is very important. You got to tread lightly when bashing PE on social media, because people always think that you're going after them personally if you bash PE, but you really need to talk about talking about the system, not necessarily them, because people tried to attack me on social media at one time, and I just was very careful not to counterattack, but just to sort of explain myself and not make anything personal. So, and PE is monitoring social media. Nothing is private or confidential. Don't assume that that's anything that you say online is going to be confidential. They measure the sentiment and they use it for marketing. So there's a common PE marketing strategy, the thing that was different than ours, which Dr. Konda talked about. This is advertising from that we get from PE and Derm. The value of your dermatology practice has never been higher, never. And they showed a picture of an older guy who's ready to retire. What's your practice worth? We buy practices nationally, and all you have to do is scroll down to the end of the email, and you'll see a young female. They're targeting females to now is the time, join us. So they want to buy the practice from the retiring physician and employ the younger female physician. That's sort of the impression that they're going after, and this is how they sort of divide and conquer the generations, which causes a lot of friction. So the new paradigm, and this has been referred to earlier, is pharmacy, dental, medical, optometry students going to this Rocky Vista University. It's the most expensive professional school in the country. I think it's more than $500,000 in debt, and to get out, to be able to pay that debt, you need to work for get a predatory job at a healthcare corporation. So it becomes like a cycle that everybody's falling into now. All the recent graduates who are saddled with all this debt are falling into this cycle now. And something I think that this has been really helpful for me to explain, PE without being sort of judgmental, is I quote this Malcolm Gladwell quote to people, and it really, I think, strikes a chord. So I'm going to read it. Those three things: autonomy, complexity, and connection between effort and reward, are, most people will agree, the three qualities that work has to have if it is to be satisfying. So I like to ask people, and all of you can sit here and think about, how many of those three things do you have in your career? And if you don't have all three, I mean, it's likely that you're not really going to be happy with your job. Autonomy, complexity, and a connection between effort and reward. So, PE, again, is what they really do is take away your autonomy. That's the #1 thing, and then the rest of the things start to decrease as well. So PE firms hire well-known physicians as messengers. They try to capitalize on their reputation, fame, and the doctors, if you call them out on it, they get very defensive when their ties and conflicts of interest are exposed. So you have to be careful of that. And it's a very common way for PE to sway would-be recruits. So, you know, one in our paper that we published in our JAD journal, so we found this one private equity group had the director had two brothers who were influential dermatologists. So, you know, sometimes it can be subtle and requires like lots of digging to figure out these connections. And again, this exposure of COI, you know, caused a big, you know, hubbub and within dermatology, and when they were exposed in the New York Times. And here's some examples of media, you know, about private equity that, you know, cause a lot of exposure in COI, especially in dermatology. So the last thing I'll talk about is, you know, working to change professional societies from within. I mean, there's an excellent podcast and story about Dr. John Patrick Spiegel, who was the former president of the American Psychiatric Association, who, you know, I think you guys would really enjoy it if you want to look it up. So studying the bylaws of your professional society and learn the loopholes and COI rules, those are very important to know what the conflict of interest rules are for your leadership. And remember that they can change those rules, you know, on the fly or whenever they want to. And change.org positions work, you know, when in using social media, you can crowdsource them and advertise them. So this is the story. It's called 81 Words. It's a This American Life episode. It's a fascinating story about how one group changed. They were able to change the whole platform of the American Psychiatric Association and make changes to the DSM. So here's an example of change.org working in dermatology, where someone started a change.org petition. They were able to remove a board member who was doing some unethical things. And so this is sort of like a plan of action. So what can you do? So publishing and responding to peer-reviewed research and literature. If you're a reviewer for your medical journal and you see something like a PE quality of care study, you know, be skeptical of it. And you can, again, continue to research the freely available data on PE to bolster your efforts. So gathering stories, I really think that this is super important. And this is, in my opinion, PE's Achilles heel. Most of the money doesn't come from Wall Street. It comes from pension funds, unions, and institutions, and they may pull money if there are abuses. So another really important thing, foreign funds, another super important thing. If people understood that there was foreign money in the healthcare system and people were, foreign governments or foreign entities were profiting from it. We really need to publicize these stories of doctors who are asked to compromise their ethics. I think they're very powerful, and well-intentioned journalists can really help with that as well. So understanding the priorities of different docs by career stage, age, life situation. We really need to stop the exploitation of non-physician practitioners and show young dermatologists other options to pay loans, like the last speaker was discussing. We have, again, research in dermatology showing the importance of training, which I think, you know, is extremely important in making that argument. So be aware of influential leader recruitment, and profiteers are the ones that are really in charge. There are lots of legal challenges to CPOM that a couple of them have been successful. So for private insurance, you know, they can invalidate the payments that they've made to these entities if they find that the organization that you know, billed them are non-compliant or fraudulent. So OIG and U.S. attorneys, again, they're very interested in any abuses that you can, you know, prove and have documentation on. When you accept Medicare, you attest to abiding by state laws, another important thing, and that means, you know, supervisor laws too. So work to change the professional societies within. The Tennessee Radiology Society had an interesting where they were able to, you know, make some changes in the CPOM laws and protect themselves in Tennessee. And it's very important to hold your professional societies and their leaders accountable to their own COI rules. And that's it. Thank you, Mitch, and take EquityBacked staff. Please email me with any questions. Thank you.
Thanks, Dr. Francis and Dr. Konda. That was honestly excellent insight, because even though EM is further along in sort of the whole sellout process, you guys have done so much work in research and advocacy that these lessons are invaluable.